I'm going to talk about two things this evening. We'll see how we go on time. But there is a theme really around sort of rational use of common pediatric presentations and particularly who needs one of those painful invasive procedures that Jess was talking about, which was lumbar punctures. So here we go. To start us off, I'm going to, Marty's just going to put a poll up on your screen. And if you wouldn't mind just answering this question, which is, you've got a 6-week-old that comes into your hospital, and their only real presenting complaint is fever. You confirm the fever, their vitals otherwise look okay, baby looks okay, he seems to be drinking. You can't really find a source despite examining this child. And so I've given you 5 options in terms of what you might do. If you don't like any of my 5, I'm sorry, it's tough luck. Then you just have to make do with one of those or abstain. Marty, I'm not sure that I can see the poll because of the slideshow mode.
Dear, let me just quickly see if
I'm sort of out of Teams. Let me see if I can go back into Teams.
Okay, just can you see it now?
Yes, I can see it, yeah, but I can't see the results.
Fantastic. Okay, great. I will share the results when it's done.
Cool.
So and people can answer that.
So let's see what people said.
Great, so there's some answers coming through. I'm just going to give it 5 more seconds, get to at least a third of the people to answer. Interesting.
Looking forward to it.
Okay, great. So about 50% have answered. I'm going to give it 3, 2, 1 and end and share the result. Can you guys see that?
Okay.
So we've got observe. 19%. I thought observe and admit for 6 hours was very much the same, and I see the other people also thought so. So 18%, so say about 38% for observe for 6 to 12 hours. Admit, okay, do a Moxil, only 2%, and then there's 40%. So overwhelming said admit, perform a partial septic screen, and start empiric IV antibiotics.
Cool. Thanks, Marty. I think for the sake of time, let's skip over the next one because it's quite similar. This was really just wanting to ask the question, and you can think about it as I talk, whether you would do anything different if it was a 10-week-old versus a 6-week-old. Okay, so the sort of theme that I'm looking at this evening is this question of what you were doing there when you decided how you wanted to manage the patient. Is I think you were probably all considering the fact of this child that looks well but has a fever and is young, 6 weeks only. My examination is not showing something up, but could I be missing something? And what you're worried about missing is could be called a serious bacterial infection. And the way that would be defined would be either a urinary tract infection or a bacteremia or septicemia or a meningitis. Could be a pneumonia, but we know that a lot of pneumonia is not bacterial. And there might be something that you would have picked up that we're not really worried about here, something like an omphalitis or a cellulitis or musculoskeletal soft tissue infection, which would have been probably picked up clinically. So you've got this conundrum of, are you missing a possible serious bacterial infection? And why are you worried about it in these particular patients? Well, because we know that babies are liars and that they can look well and yet be harboring a nasty bug. And the other thing, and this is the picture referring to the sort of question of gambling, what we're also weighing up here is what is your appetite for risk? So how brave are you? How much do you want to risk missing something versus how much do you want to risk doing something unnecessary? And historically, this question has been, or the answer to that question historically would have been that any child under the age of 3 months should get a full septic screen, should get admitted and wait for their cultures to come back negative, get intravenous antibiotics, and probably a lumbar puncture as well. And then probably about 2, maybe even 3 decades ago, probably more in the last 2 decades, or decade particularly, there have been declining rates of SBIs, particularly due to organisms that we now know how to prevent, whether it is Group B strep screening and prophylaxis, whether it's pneumococcal vaccination or Haemophilus vaccination. And so our worry about missing something has gone down to a certain extent. But also we know that basically the younger you are, the higher your risk. And as you get older, this risk is progressively decreasing. So do we need to think about at what age the kind of balance shift towards it's less prevalent and you can change your practice? Because there's no real debate. If I had to tell you that was a 3-week-old or a 2-week-old, I think most people would have agreed that you would have done option 5. What we're trying to balance here is not missing an SBI versus unnecessary admission, an invasive procedure like a lumbar puncture, unnecessary antibiotics, rising healthcare costs, that sort of thing. We also need to consider what our context is. So in a place like South Africa or in Africa, do we have the same prevalence of SBI as the international community and what they're doing? Do we have more risk factors like HIV, malnutrition, HIV exposure, lack of breastfeeding, incomplete immunizations, and our health system, lab turnaround times, parents' ability to come back or be available for a telephonic follow-up, that sort of thing. But there has been quite a lot of work, and really in the last few years, in terms of saying, well, can we do a little bit better in terms of trying to hit the target and not be admitting so many children, not doing so many invasive procedures? I'm sure many of you are familiar with the NICE guidelines, and really these were developed in about 2013 and haven't evolved much in this space. And this is why I wanted to talk through some other recent papers. And although it says 2021, this part of the guidance hasn't really changed. And so NICE recommends under 3 months old, every baby with a fever should get a urine dipsticks, a CRP, a white cell count, and a blood culture. And then who should get a lumbar puncture? And that would be less than 1 month, or if you are unwell between the age of 1 to 3 months, or if your partial septic screen comes back positive in terms of your inflammatory markers. And those babies only would get IV antibiotics and a lumbar puncture. And the unwell would be this sort of red traffic light sign that's shown there. And they use white cell count as their guide in terms of inflammatory markers. Just wanted to show you an updated South Australian guideline where they have now made it an applicable guideline for 1 to 2 month olds. So they follow neonatal pathways for less than 30 days and pediatric pathways for more than 2 months. And their approach is very similar. They say if the baby has any of these red flag signs or toxic signs, then they are high risk, or if the inflammatory markers come back as shown there, those are high risk, and you would only lumbar puncture those children. The others, you potentially are going to either just discharge or observe for a bit longer. And here is their flow diagram. And really what they're trying to do is say that if you've got any high risk features, you should be admitting for antibiotics, deciding about antibiotics with a specialist. But if you've got no negative inflammatory markers, no high risk features, those children could actually be discharged. I'm now in darkness due to load shedding, but hopefully you can still see my screen. I just wanted to show you our Western Cape protocol that we use at our hospital, and this is divided into 0 to 1 month and 1 month to 3 months. And we have a similar sort of strategy where if you've got some of these high risk symptoms, so looking toxic, to use the Australian terminology, or red criteria, high risk criteria, to use nice terminology, these children are getting, in the 1 to 3 month age group, a full septic screen and antibiotics. But if you go on to the, if you don't have that, then it's stratified into babies that we think maybe have a respiratory illness, and we manage them according to the respiratory protocols, or have actually no high risk or medium risk features, and these children are admitted and just get a urine dipsticks. But the approaches that I've mentioned in recent years have been attempted to be refined, and really it's about trying to get a little bit more accurate in terms of preventing unnecessary admission and investigations. And so I just want to show you a summary here of an older algorithm that used white cell count and bands and urine to stratify, and it performed fairly well, but wasn't quite as sensitive. It was 82% sensitive, and these rules which have been developed, step by step, and the PCON rule, use PCT. And that is a problem because procalcitonin is not always available in our setting. But these tests have got very high sensitivity and very good negative predictive values. And then most recently, the American Academy of Pediatrics came up with a guideline, which I'll show you on the next slide. But just on this slide, I want to show you that what they did do is they've used an absolute neutrophil count cutoff and a temperature cutoff and a urine. And they've said that even if you don't have a CRP or a PCT, we actually get pretty good sensitivities and negative predictive values. But what is different in the AAP that is potentially worth considering? Well, the first is that in fact their cutoff now for the neonatal period has become 21 days, and their upper limit has become 60 days. And so again, our Western Cape algorithm and NICE use 3 months, but there seems to be quite a strong move in the newer studies that are being performed to drop that cutoff to 60 days or 2 months. Also, the preference seemed to be, we know that PCT is better at CRP in terms of bacterial infection, but there's a cost issue. And it seems to be that absolute neutrophil count is possibly a better marker than total white cell count. The other thing that changed in AAP, which I found quite interesting, is how long you wait for a blood culture to say that it's negative. And this really seems to have come about from, historically, we were always taught 48 to 72 hours. And now with automated blood culture monitoring, in fact, the detection time has reduced. And so you can see from this graph and this study done that, in fact, 96%, 91% of pathogenic bugs were picked up by 24 hours, 96% by 36 hours, and 99% by 48 hours. And that means that if you want to keep your child for more than 24 hours, you will observe between 500 to 1,200 infants to pick up one pathogenic bacterium. So I think this is potentially something to consider when we are deciding if it's like 34 hours or 23 hours and we need to keep them another day or till the morning and we got bed pressure, just something to think about. The question does arise is do these things work in our setting, and do we have similar incidence rates of bacterial infection, and how do we apply these guidelines? We did a study here at Tygerberg and of all children 21 to 90 days. What we found is that the 21 to 28 days and the 29 to 90 days were similar, with rates of about 5% of either bacteremia or meningitis, 25% S. overall. So a bit higher, but this included probably some viral pneumonias. We looked at the performance of the WHO criteria, which is what we use to identify these children, and it was okay. But you can see why we don't rely on clinical criteria only. We want to do special investigations. And what I wanted to really highlight here is, and I don't know if Tygerberg is unique in this or if this is South Africa over, but we are really bad at getting urine samples. And if there's one thing that I'd like to sort of say in this talk is we really need to get better at doing urine collections in these patients. So in summary, with some of the new research that's coming out, nothing much has changed with regards to neonates. I think most people would agree still to do a full septic screen in a baby that has a fever or you're considering possible neonatal sepsis. Consider things like herpes simplex virus and give them empiric antibiotics. But there definitely is a role for, in the more than 1 month old, for a partial workup, and then to consider whether they do need admission, whether they do need antibiotics, and whether they do need a lumbar puncture. We seem to have good tools now that are very good at identifying the baby at low risk, given a combination of clinical features and special investigations. The question that I'd like to leave with you is just some thoughts around what do you think about adjusting the age cutoff from 3 months to 2 months? If you are admitting children and waiting for results, do you give them empiric antibiotics, or actually do you wait for your results and then potentially you haven't given them unnecessary antibiotics? And maybe we should be just reconsidering, or on a case-by-case basis, just thinking, is it really necessary to keep that child beyond, say, 36 hours, which means another day in hospital, for example, and the cost that brings in terms of hospital bed occupancy, but also potential risk for hospital-acquired infection and inconvenience to caregivers. So, Marty, I wanted to just wonder if I should stop there and we leave febrile convulsions for another time.
Yes, I think we will unfortunately have to. We can maybe share the slides with the people on our website, and then next time go through the fitters and the critters, unless you quickly want to do a summary. I don't know if you've got a good summary slide for that.
Yeah, let me do that.
Okay, great. We can maybe do the summary slide, and then we'll quickly get to 1 or 2 questions. We should be done by 6:15. Thank you, everyone.
This was the summary. Again, it's in the context of reduced rates of bacterial meningitis with immunization campaigns and new research in the area of febrile convulsions and new guidelines being released. I think basically what the change is previously, probably in the 12 to 18 month group, you would consider doing a lumbar puncture. Now, if you have a simple febrile convulsion, you are fully immunized, you haven't been given antibiotics by someone else, and you have even if you don't have a clear source, but the child looks well, you probably don't need to lumbar puncture them. The ones that you probably do still need to lumbar puncture is under 12 months, anyone obviously with signs of meningism or who presents in febrile status. Where there is maybe a bit of a gray area is still whether children with complex febrile seizures are at increased risk. And then obviously we have a lot of children with potential immune compromise from a variety of reasons or incomplete immunizations. And those more than 12 months old, you'd have to, I think, take on a case-by-case basis.